Imagine trying to inject a highly viscous structural gel into a biological space where the margin for error is literally measured in millimeters.
Yeah, and a single slip could result in permanent, agonizing tissue death. It is incredibly high stakes.
Right. And today, we aren't talking about facial reconstruction or knee joints or anything like that. We are talking about the fastest growing trend in aesthetic medicine.
Yeah.
And is happening entirely below the belt.
Which is honestly an absolute masterclass in human biomechanics. I mean, for decades, the aesthetic conversation has been dominated by, lips, cheeks, jawlines.
The stuff everyone sees.
Exactly. The map is literally written on your face. But there's this massive shift happening right now toward hyaluronic acid fillers for vaginal rejuvenation, specifically labia majora augmentation.
And the moment you transition to that area of the body, that visible, easily navigated landscape becomes an incredibly complex, highly vascular maze.
Oh, absolutely. The structures are delicate, they overlap constantly, and the physiological consequences of a mistake down there are severe.
Which is why today our Deep Dive is dedicated to answering one highly specific, incredibly complex clinical question for you.
And it's a question of safety, really.
Exactly. How exactly does a clinician perform this procedure safely? Like, how do they ensure that a syringe full of filler stays strictly within the labia majora and entirely avoids accidental entry into sensitive structures like the labia minora or the clitoral hood prepuce?
Well, to even begin answering that, we have to establish why someone is injecting this area in the first place. What is physically happening to the tissue as a person ages?
Right, because things change dramatically.
They really do. The female genitalia undergo profound changes due to childbirth, and especially the estrogen drops associated with menopause.
So when we talk about minimally invasive treatments offering results here, it requires a perfect understanding of the underlying geography. Let's map out that terrain for a second.
Yeah, let's do it.
So you have the labia majora, right? Or the outer folds. And those were primarily made up of subcutaneous fat and fibrous tissue.
Right. They act as a protective barrier.
Exactly. And then inside those outer folds, you find the labia minora, the inner lips.
Right.
And unlike the outer folds, these are made of highly sensitive mucosal tissue.
Which is a crucial distinction, fat versus mucosa.
Yep. And anterior to all of that, you have the clitoral hood, which is the skin overlying the clitoris, with the prepuce being the specific fold of skin surrounding the clitoral glands itself.
And the key here is what happens to that protective barrier, the majora, over time. With age, or with that estrogen deficiency that comes with menopause, the entire architecture begins to shift.
It's clinically referred to as genitourinary syndrome of menopause, right?
Yes, exactly. Because estrogen is vital for maintaining collagen production and fat distribution. So when those estrogen levels plummet, the fat pads inside the labia majora literally atrophy.
They just deflate?
Deflate and wrinkle. The skin loses its elasticity, the collagen network degrades, and those outer protective folds just kind of melt away.
And the clinical data reveals this fascinating psychological and physical phenomenon stemming from this deflation.
Oh, it's so common.
Patients frequently walk into a clinic complaining that their inner lips, the labia minora, have suddenly grown.
Yes. They feel discomfort, friction against their clothes, and they truly believe the inner structures are enlarging.
But the anatomical reality is often what clinicians call a pseudo-protrusion.
Right, because the labia minora didn't suddenly grow.
It's the frame around it that shrank.
Exactly. The labia majora, that outer protective layer that was meant to encase everything, shrank away. And the deflation of the outer structure suddenly exposes the inner mucosal structures that were, well, they were always there.
They just weren't exposed.
Right. And now they're projecting past the boundary of the majora, leading to physical friction and significant discomfort.
It's like, imagine a picture frame shrinking over decades, right?
Yeah.
Shrinking so much that the picture inside looks like it's bulging out of the glass.
That's a perfect analogy.
And the historical surgical approach was often to take a pair of scissors and just cut the picture. To reduce the labia minora surgically, even if they were a totally normal size, just to hide them again.
Which is drastic. But volumizing the majora with filler aims to restore the frame, providing that protective closure once again without amputating healthy tissue.
Which conceptually makes a ton of sense. But physically, it introduces the massive challenge we are dissecting today.
Introducing a foreign volume into a microscopic space.
Exactly. Wait, hold on, though. If these tissues are literally millimeters apart, It sounds almost impossible to restore the frame without accidentally injecting the picture.
It is incredibly precise work.
Because the clitoral prepuce and the mucosal tissue of the inner lips, they're practically intertwined with the outer folds. Isn't going there with a needle basically playing Russian roulette with the anatomy?
It would be, yeah, if they used needles.
Oh, okay. So how is a clinician physically preventing the tip of a syringe from slipping just a millimeter too far to the left?
The secret is completely abandoning traditional sharp needles for the actual volume placement.
Wait, really? No needles at all?
Well, almost none. If a practitioner were just haphazardly poking around with a sharp hypodermic needle, the risk of piercing the labia minora or the clitoral hood would be astronomical.
Right, because it would just slice right through.
Exactly. So instead, they rely on blunt tip microcannulas.
Okay, so if you're trying to picture a cannula, imagine a tiny, flexible, hollow metal tube. But the tip isn't sharply beveled like the needle they use to draw your blood.
It's perfectly rounded.
So it can't pierce anything.
Right. Because it's blunt, it physically cannot pierce intact skin on its own. The clinician has to use a sharp needle exactly once to create a microscopic entry
A
hole.
pilot hole, basically.
Exactly, usually at the very bottom, the lower pole of the outer labia. And once that tiny pilot hole is established, the sharp needle is disposed of.
Okay, and then what?
The clinician then takes the blunt cannula and threads it up through that pilot hole, navigating underneath the skin.
So as that rounded metal tube moves through the internal tissue, it's not slicing a path, it's physically nudging structures out of its way.
Yes, that mechanical difference is the primary line of defense, because the labia minora and the clitoral prepuce are denser mucosal tissues compared to the loose connective tissue and fat of the majora.
So when the blunt tip hits them, it bounces off.
Essentially, yes. When a blunt cannula encounters a blood vessel, a nerve, or the denser boundary of mucosal tissue, it doesn't cut through it. The blunt tip hits that resistance and slides past it.
Wow, okay.
The clinician relies entirely on that tactile feedback. They can physically feel the distinct resistance of the tissue layers through the instrument.
But it's not just about the tool, though, right? Because the margin for error is also vertical. Depth has to be just as critical as lateral placement.
Oh, absolutely. The human body is layered, and you absolutely cannot inject hyaluronic acid filler into the mucosal tissue of the inner lips.
So where exactly does it go?
It has to be placed in a highly specific anatomical plane within the outer folds. Specifically, it requires threading that cannula into a microlayer between the tunica dartos and the fibrous layer of the adipose sac.
Okay, let's break down those layers for a second.
Sure. So the tunica dartos is a very thin layer of smooth muscle located just beneath the skin of the labia majora.
And what does that muscle do?
It's responsible for the slight wrinkling and thermal regulation of the area. Now, beneath that muscle layer is the actual fat, the deep adipose tissue.
And that fat is contained within a sac.
Yes, a fibrous sac. So the clinician must guide the blunt cannula exactly between that smooth muscle layer on top and the fibrous sac containing the fat on the bottom.
It's like trying to inject filling into the exact center of a layered pastry.
That's a great way to visualize it.
You have to slide the tip in beneath the delicate upper crust without breaking through it, but you also can't pierce the dense bottom layer.
And they are doing it blind, relying entirely on how the tissue feels as the cannula glides.
What happens if they miss that layer? Like if they go too deep?
If the practitioner goes too deep and pierces the adipose sac, the filler just disperses into the deep fat. It completely ruins the structural plumping effect.
So the product is essentially wasted.
Entirely. But if they go too superficial and inject above the tunica dartos, the product can migrate into the wrong tissue entirely.
That sounds bad.
It is. It creates lumps, discoloration, and potentially starts tracking toward those sensitive inner mucosal structures.
So to ensure the volume distributes perfectly within that specific pastry layer, clinicians use a technique called retrograde linear or fan-shaped retrotracing.
Right, which sounds complicated, but it's just about how they release the gel.
So they push the cannula all the way in along the longitudinal axis of the outer labia, moving from the bottom toward the top.
And then instead of just pushing the plunger and leaving a big blob of gel,
Which would be terrible.
right, they slowly inject microscopic controlled amounts, sometimes just 0.125 milliliters at a time, as they pull the cannula backward.
And the choice of filler is also vital here, right? They aren't just using standard liquid.
No, they are using highly cross-linked hyaluronic acid, often mixed with an antioxidant called mannitol.
Cross-linking means the individual hyaluronic acid chains are chemically bound together. It turns a watery liquid into a dense structural gel that resists degrading.
And the mannitol helps protect the gel from free radicals so it lasts longer. They aren't just filling space. They are creating a highly precise structural scaffold, an extracellular matrix.
It's architectural rebuilding, microdrop by microdrop.
Exactly.
Okay, so we have the blunt cannula pushing sensitive structures aside, and the precise tissue plane keeping the filler contained vertically. But if depth is only half the battle, how does a doctor know exactly where to place the volume horizontally without messing up the entire shape?
Because you can absolutely ruin the anatomy just by misunderstanding the biomechanics of the tissue.
Yeah, you can accidentally expose the clitoral hood and the labia minora without ever touching them directly with the cannula just by putting the filler in the wrong part of the outer labia.
It's true, which is why they rely on a highly rigorous mapping system to prevent this.
Right. The clinical protocols detail a systematized approach called the vulvar anatomical vector technique.
And this maps out 5 distinct vectors labeled VA1 through VA4 and VAS to reconstruct the labia majora safely and functionally.
Think of these vectors as a strict architectural blueprint. VA1 is the medial border, the innermost edge of the deep fat pad, right next to where the outer lips meet the inner lips.
And the clinical goal of injecting VA1 is coaptation.
Coaptation. What does that mean in this context?
Coaptation is the medical term for surfaces joining together perfectly.
Okay.
By meticulously rebuilding that inner border first, the clinician ensures the outer lips will close properly over the inner lips and the clitoris.
It reestablishes that physiological protective seal that was lost when the fat pads deflated during menopause.
Exactly. Then you move to VA2 and VA3, which are the lateral injections.
So these are placed further out toward the sides of the body, away from the midline.
Right. The purpose here is outward projection, smoothing out the lax skin and wrinkles on the outside of the labia majora.
But there is a massive warning in the clinical guidelines about these vectors.
A golden rule, really. And it completely shifts how you have to think about filler.
The protocols explicitly warn that VA2 and VA3, those outside lateral injections, must never be performed without first fully reconstructing VA1, the inner border.
Never.
Because if a doctor ignores the map and only injects the outside edges of the labia majora to plump them up, the volume actually pulls the surrounding tissue outward.
The filler acts like a lever.
Exactly. It causes the labia majora to separate and pull apart, which completely exposes the clitoral hood and the labia minora.
By trying to plump the outside, they achieve the exact opposite of what the patient wants, leaving the delicate internal structures entirely unprotected.
It's like if you build up the outside of a set of double doors, the weight pulls the doors open.
Right. You have to build up the inside edge first so the doors are forced to meet in the middle.
So the structural mapping is non-negotiable because it leverages the physics of the filler to push the tissue toward the clitoris, rather than pulling it away and leaving it exposed to constant friction.
It's brilliant engineering when done right.
But, so we know a misstep can expose the wrong tissue. Anatomically speaking, though, the stakes are actually much higher than just a bad aesthetic result or a bit of chafing, right?
Much, much higher.
Let's talk about the vascular network down there, because this is where the precision of staying in the exact right plane becomes a literal matter of tissue survival.
Yeah, we have to talk about the blood vessels. The vulva is one of the most highly vascularized regions in the human body.
It's incredibly dense.
It is. Its blood supply is supplied by the anterior and posterior labial arteries, along with extensive branching from the internal and external pudendal arteries.
It is an intricate, overlapping highway system of blood vessels crammed into a tiny geographic area.
And if a clinician loses track of where that cannula tip is, even by a fraction of a millimeter, and they inadvertently inject thick, highly cross-linked hyaluronic acid filler directly into one of those arteries,
It causes a catastrophic intravascular occlusion.
which is as bad as it sounds, the dense structural gel acts as an immediate plug.
It just stops the blood flow.
Instantly halts all blood flow through that vessel. The tissue downstream from that plug is suddenly starved of oxygen and nutrients.
And within minutes, the tissue becomes hypoxic.
And if the blockage isn't cleared rapidly, that tissue will die. It will undergo necrosis.
The documentation of these complications in the sources is harrowing. There's a specific case study of a 47-year-old woman who underwent this procedure.
I remember reading that one. It's tough to read.
Yeah. Due to improper technique, she suffered a severe vascular occlusion. And 7 days post-injection, she presented with agonizing pain and necrotic skin ulceration.
Her tissue was actively dying and sloughing off because it had been suffocated.
And to even attempt to heal her, the medical intervention had to be extreme. They performed super-selective intra-arterial thrombolysis.
Meaning they had to physically thread a catheter deep into her arterial system, navigate it directly into the specific blocked artery in her pelvis, and inject highly concentrated, heavy-duty clot-busting drugs just to dissolve the blockage.
And even then, they had to apply concentrated growth factor therapy over a long period just to coax the dying tissue back from the brink.
And that's not even the worst-case scenario.
No.
The literature also cites an even more critical cascade resulting from an illegal, botched cosmetic vaginal procedure, a hyaluronic acid pulmonary embolism.
A pulmonary embolism.
Yeah.
Meaning the practitioner accidentally injected this thick structural gel into a vein rather than an artery.
Yes.
And the gel traveled freely through her pelvic venous network, flowed up into her inferior vena cava, passed entirely through her heart, and finally wedged itself into the delicate blood vessels of her lungs, instantly compromising her ability to breathe.
Which is terrifying. And it just goes to show, the proliferation of genital rejuvenation marketing on social media and at luxury med spas often frames this as a casual lunchtime tweak.
Like getting your lips plumped.
Right. But the reality of the vascular anatomy proves it is an advanced, highly specialized medical intervention.
So to ensure they never induce a vascular occlusion, legitimate clinicians follow incredibly strict safety protocols.
They have to.
The blunt cannula is step one, allowing them to push those pudendal artery branches away rather than piercing them. But step two is continuous aspiration.
Aspiration is crucial. It's the mechanical act of checking your placement before committing.
So how does that work?
Before the clinician pushes the plunger to release even a microdrop of filler, they pull back slightly on the syringe.
Which creates negative pressure.
Exactly. And if the tip of the cannula is accidentally resting inside a blood vessel, that negative pressure will pull a flash of red blood into the clear hub of the syringe.
So it's a visual warning system.
Yes. The moment they see that flash of blood, they know they're in the danger zone. They immediately stop, withdraw the cannula, and reposition it into safe tissue.
And they also inject excruciatingly slowly, right?
Very slowly. By introducing the volume at a glacial pace, the surrounding tissue has time to stretch and accommodate the product.
Because if you inject too fast, the pressure builds up in the confined space, which can actually compress a nearby blood vessel from the outside until it collapses.
Right, cutting off blood flow even without the filler being inside the vessel. It's called compartment syndrome.
Which brings us to the ultimate safety net, hyaluronidase.
The eraser.
Right. Hyaluronidase is a naturally occurring enzyme, but in aesthetics, it's used as an emergency reversal agent.
It specifically targets the glycosidic bonds in hyaluronic acid.
So when it's injected into an area filled with HA, it cleaves those chemical bonds, turning that thick, cross-linked structural gel into a watery liquid in a matter of minutes.
Allowing the body's lymphatic system to just flush it away.
So if a clinician is performing the injection and suddenly sees the skin of the labia blanch, meaning it instantly turns white or dusky because the blood supply has been compromised, they have minutes to react.
Minutes. They have to flood the area with hyaluronidase to melt the filler and unblock the artery before irreversible necrosis sets in.
If the person performing the procedure doesn't have vials of hyaluronidase sitting open and ready in the room, they have absolutely no business touching this anatomy.
None whatsoever.
So the synthesis of all these techniques is what separates architectural reconstruction from a dangerous gamble.
Absolutely. They utilize the blunt-tip cannulas to respect the mucosal boundaries.
They rely on tactile feedback to secure the precise microplane between the tunica dardos and the deep fat.
And they rigidly adhere to the VA1 medial border vectors to ensure the structural tension pulls the tissues together protectively rather than prying them apart.
It's incredible. Whether you are actively researching female wellness procedures or you are simply fascinated by the intricate biomechanics of the human body, understanding the rigid underlying science is the only defense against slick marketing hype.
It really is. It highlights the absolute brilliance of modern applied anatomy when executed by a master, and the terrifying consequences when attempted by a novice.
And, the evolution of aesthetic medicine into these functional, highly sensitive areas is forcing a reevaluation of how we categorize aging and wellness.
It's a huge conversation in the medical community right now.
Because the clinical literature even hints at procedures like G-spot amplification injecting fillers into the anterior vaginal wall to potentially enhance sexual function and pleasure.
Which really blurs the line between cosmetic enhancement and functional medical treatment.
Completely. I mean, if menopause causes physical discomfort, severe friction due to tissue deflation, and a loss of sexual function that drastically impacts a person's quality of life.
Yeah.
The classification of these procedures becomes complicated.
Are they purely elective cosmetic surgeries?
Right. Or is this level of precise architectural reconstruction a form of essential restorative health care that perhaps insurance should eventually cover?
It's a valid question. It asks us to look closely at how the medical community values and supports the reality of female aging and physical comfort.
A broken bone on an X-ray is clean and visible. The world of below-the-belt aesthetics is often hidden, layered, and anatomically treacherous.
But just because the terrain is hidden doesn't mean the science isn't exact.
Exactly. In the right hands, it's precise structural architecture. Thanks for taking the plunge with us today. Keep questioning the hype, keep seeking the science, and we'll catch you on the next deep dive.